talk about some of the new treatments. Is there anything else on the horizon with
Right.
some of the new treatments that you're doing now?
So the so-called new treatments, there's one very, very important drug that's out there now. It's referred to as a proteasome inhibitor, and it actually, the tumor cells, normally we have to get rid of our old proteins that keep the cells alive. And so normally there's something in the cancer, in all cells, called the proteasome, and it helps get rid of dead proteins so that the new cells can be made. Well, they found that this proteasome in cancer cells, especially in myeloma cells, is overproductive. And so they now have developed a drug called a proteasome inhibitor, and it's called Velcade. So Velcade is used in combination with prednisone, in combination with thalidomide, and in fact, thalidomide is not used as commonly now because they found one that's much more potent than thalidomide, and that's called Revlimid. Another name for that is lenalidomide. So these are all new drugs that now they're adding together, very much like we did for leukemia and lymphoma years ago. We're putting combinations of drugs together, and we're making cocktails, and that is becoming much more effective. So multiple myeloma is no longer a disease where people die within 3 years. The advent of bone marrow transplant actually has prolonged the life of multiple myeloma patients, and actually the standard of care for many years has been using these new drugs, the Velcades, the proteasome inhibitors, the lenalidomides, the prednisone, get rid of the tumor as much as you can, clear out the bone marrow of these abnormal cells, and then we can actually take the patient's own bone marrow, sort of freeze it away, and give the patient a little bit more higher dose chemo to get rid of the last cancer cell in their body, and then we transplant them back with their own bone marrow cells. And that's not really a transplant, it's just giving them back their own bone marrow cells so that they will have normal blood counts after this high dose chemotherapy.
Right. And again, because we've made leaps and bounds, as we've talked about, years ago you said it was 3 years basically. What's the survival rate that you're looking at nowadays?
Well, if you put everybody together and bone marrow transplant and survivors, we're talking well into 7 years and longer. And many of my patients with multiple myeloma are out 15 and 20 years and doing very well. So remember, it's an individual.
Right.
You can't say, oh my God, I'm only going to live 7 years.
Yeah.
No.
Yeah.
I mean, everyone is individual.
Yeah, and that was one of the things we always said too, because, when they say they'll go on statistics, but everybody's individual, and they'll take like everybody in the whole universe and put everybody together, but it depends on your health, your age, everything goes into it, and where you are when you're going into treatment.
And we should mention that I get so many referrals because doctors will pick up increased protein in patients' blood. The majority of these patients do not have multiple myeloma, but the referring doctor sends them to us to make sure they don't have multiple myeloma. So there's something called an MGUS. MGUS, monoclonal gammopathy of unknown significance, and patients can live with that forever, and they're not going to necessarily develop multiple myeloma. So, if your doctor says, oh, you've got too much protein in your blood, I'm going to refer you to a hematologist. I mean, the first thing people do is they look up too much protein and they see multiple myeloma and they're scared to death. So we need to make sure that everyone understands that there are many other reasons for having too much protein in your blood. It does not necessarily mean you're going to have multiple myeloma.
Right. And as far as like the on the horizon, where do you see, as far as myeloma, like the treatments where we can be in another 10 years?
Yes, many of the treatments today are relatively non-toxic, and I think that I don't want to put the transplanters out of business, and I know Dr. Fung would be very upset if I said that we would, but many of us think that with the newer agents and patients going into really some very good remissions, which mean we don't find any evidence of the cancer in them anymore, and that's happening with some of these newer drugs even without going to transplant. And so investigators are talking about maybe not doing transplant right away if the patient has a wonderful response with some of these newer agents, but perhaps saving some of those cells frozen away, and if the disease comes back, talking about transplant maybe a little bit later. And so there are newer agents that are prolonging remissions, and even looking now at survival with some of these newer agents and combinations. And maybe transplant is going to be something that won't be used as a routine or as a standard of care.
So something, these other things will kind of take
the
place
of perhaps.
It, right. Well, and again, we've talked about, and I've talked to you many times about this as far as research, and that's one of the things that we do is we want to get research dollars into researchers and, specialists like yourself that can actually find new treatments, because that's how we find the treatments that we're doing now. 10 years ago, we didn't have that kind of treatments that we do today, so we're doing leaps and bounds. And what I'd like to talk to you about is, Dr. Gregory, is clinical trials, because we've talked about this before. And a lot of people are afraid of them or they don't understand them. So I wanted you to just kind of cover, if you could, and just to let some of our viewers know that they're not the scariest thing that people think they are.
So I think the first thing I'd like to say is, please don't ever think that patients are used as guinea pigs. I mean, that's a term that I think is really an uninformed term that has been used in the past. We like to talk about clinical trials as offering the patient not only what's pretty much standard of care for them, but perhaps adding an additional new agent without adding a lot more toxicity that may give them a better response than the standard treatment. We never talk about giving the patient what we used to refer to as a placebo. I mean, no patient today would be put on a treatment that has absolutely no effect. And when we're talking about clinical trials, most of the clinical trials we have available for patients are already in what we call phase 2 and phase 3 trials, which means that they have already been used in patients who really had nothing else that they could be offered, and it was for all kinds of cancers, and they were given these newer agents, and in certain cancers it looked like they were working. So from those early trials in patients that really had nothing else that they could be offered, those new drugs were then brought into more advanced clinical trials where they would now compare those newer drugs with a standard of care, adding it to the standard of care. So by the time we offer you a clinical trial, we're talking about trials of new agents that have been out there for years and already have been tried in many humans, and it found that they worked. So you always need to talk to your doctor about clinical trials. It will not only give you the standard of care, but will probably add a newer agent to the standard of care.
And that's what we see a lot of times, Scott and I, because we talk to many patients all the time, and we've actually seen people die because they don't reach out, and they don't, they feel like a clinical trial, like you said, is a guinea pig. And we know so many people who are living today, it would not be here if it wasn't for a clinical trial. So we always are like really pushing in, to try to find the clinical trial, because a lot of times, the universities do them, and a lot of times your neighborhood doctor may not know about them or something. So do your research, contact, and then maybe you can kind of like get into some of that.
I shared with Scott earlier that actually I saw 4 new hematologic malignancy patients yesterday. Two were lymphomas, one was a leukemia, and one was a myeloma. And one of the lymphomas that I saw was just very, very sad. It was a young girl who had a history of a Hodgkin lymphoma, which is really very curable. It's very curable even if it relapses, which means if it comes back. And so this young woman had gone through the standard treatment for her Hodgkin lymphoma, and unfortunately we don't cure 100% of patients. So her Hodgkin lymphoma did come back within a year after her treatment, and she was still very curable at that time, but she had side effects from the chemotherapy that she had received from her first treatment for her Hodgkin lymphoma, and she actually told her doctor she did not want more chemotherapy. And actually she went for herbal medicine for 1 year and was treated by a physician with herbs for 1 year. And when she finally realized that her tumor was growing, she did go to see an oncologist, a very good colleague at another academic medical center, and he recommended what should have been done a year earlier was more chemotherapy and a high-dose stem cell transplant using her own bone marrow. And she absolutely refused. And now she realizes that she needs something done because one of the tumors has grown to greater than the size, I mean it, yesterday when I examined her, more than almost a basketball.
Yeah.
And, and you know, we talk about alternative medicine. We don't want you to do alternative medicine. We want you, if you want to do something, you should do complementary medicine. Do the standard treatment for your cancer, but we certainly encourage alternatives such as good nutrition, consultation with a dietitian, massage therapy in certain instances, help for relaxation. Acupuncture has a role at certain times. It's called complementary. We should not do it instead of standard treatment.
And again, we've actually seen people like that do that, and by the time they do get to a doctor, they can treat them. And also, as far as the side effects, we were talking briefly, the side effects are so, today there's so many drugs out there that can help you with the side effects and get through them. So I know it's just, it's challenging.
And I do agree, because I think that she was treated by someone who did not even address her issues, and she was not even restaged with CAT scans or x-rays after 3 cycles, which we always do. So you need to know the physician treating you.
Yeah. We're gonna just keep going here a little. We're getting running a little on time, but just if you could just wrap up real quick and give some information to viewers, what they can do and where they can contact you or anything if they have any questions.
We have, Rush has a very, very strong hematologic malignancy program, and we are actually very, very willing to see patients. I say any cancer patient should be seen within 24 hours of making a call, and you can't find that in many centers. So our number for battling and beating cancer, we want you to call in live to 312-738-1060. If you want to call us at Rush, our number is 312-942-5982. That's my direct number. You'll get my secretary, Patricia, and we can always redirect your call.
Okay, I want to thank you. Thank you, Dr. Gregory, and thank you for battling and beating cancer. Thank you.